All right, so good afternoon, everyone. Thank you so much for joining us for a webinar on a topic that is clearly of interest to the NAMI Greater Cleveland community, as evidenced by how many of you have joined us for this webinar. And it is on the topic of motivational interviewing and understanding how skills of this therapeutic modality can be used by families and caregivers. So many of you may already be familiar with NAMI. If this is your first webinar with us, NAMI is the National Alliance on Mental Illness. NAMI Greater Cleveland is an example of a local affiliate of NAMI. We serve Cuyahoga County specifically. And is there any audio issues? I see someone in the chat said that they were having trouble hearing me. Are we okay with audio, Maddie? Can you hear me?
Hear you.
Okay. All right. Thank you. So NAMI Greater Cleveland, we serve Cuyahoga County. Our mission is dedicated to improving quality of life for individuals with mental illness and their family members. Just a few things to be aware of. So we do have a large group attending today. So I am going to ask that we largely refrain from questions until we start to wrap up. We may have a lot of questions. We want to make sure that our presenter has time to get through the material adequately. So please utilize the chat feature for questions as we start to wrap up. We did allocate 90 minutes for this webinar as opposed to an hour. So we will be running no later than 1:30 p.m. Eastern Time. This webinar is being recorded and will be uploaded to the NAMI Greater Cleveland YouTube channel later this week. And I will also send you a follow-up email after the webinar with these slides. A few other notes. So we are offering one CEU for fully licensed counselors, social workers, and marriage and family therapists. So there will be a specific evaluation that we will ask you to complete in order to receive those CEUs. You will need to provide your full name, your full license number, and your license type. Okay. These CEUs will be entered into CE Broker on your behalf, and you will also receive a CE certificate of completion that will come to you likely by the end of this week via email. So, thinking anything else that I need to mention. Remember, remain off camera if you don't want to be in the seen in the recording, and also remember to remain muted so that we can limit background noise. I think with that being said, I will pass it off to Maddie to introduce herself and get us started. Thank you all for being here today.
Cool. Hi, everyone. Thanks for coming. It's nice to see so many faces. But again, if you need to turn your camera off, I know a couple of people have asked. That is perfectly fine. Yeah, let's get started. So today we're going to do a few things. Today's training is about motivational interviewing for caregivers or loved ones of people with mental illness. So today we're going to kind of start with defining what is it that we're talking about here, a little refresher for those who are already familiar, and maybe a first brush for some of us as well with what is motivational interviewing, as well as the stages of change theory, kind of what the theory is that motivational interviewing is based upon. We're going to talk a little bit about the LEAP model of communication, which is a theory that is pretty frequently talked about in NAMI presentations, actually, that connects really well, overlaps really well with MI skills. And then the second half of the presentation, we're going to dive a little bit more into those MI skills, how they can be used not just by clinicians, but also by caregivers or loved ones with people in your family or people in your lives, and also how to use those skills with specific populations. So, what if my loved one has XYZ diagnosis, or what if my loved one is dealing with substance use disorder? So, that's what we're going to do today. A little bit about me. Um, I have consistently put my graduation year wrong on every one of these slides this year, so please forgive me. I have an MSW from CASE. I graduated in 2019. I am not amazing at proofreading my own bio. Currently, I work as a private practice mental health therapist. That's where I am today. My office is in Cleveland Heights. I specialize in working with clients with anxiety disorders, including OCD. I see a lot of LGBTQ clients. I also am working on certification in sex therapy. So I see a lot of couples and people who are dealing with sexual dysfunction as well. So that's a little bit about me. So, first things first, we're going to talk about what are the stages of change. And this might be familiar for some of you. I know my first time encountering the stages of change was in graduate school, or maybe even before that, now that I'm thinking about it, maybe even in like psychology classes in undergrad. So, the stages of change are a theory about how people move through a change process or how people decide to change a behavior. This theory came to fruition around the 1970s by two researchers, Prochaska and DiClemente. They were doing a study on people who were quitting smoking, so people who were participating in a tobacco cessation program at their university. And they were interested in finding out why. Why are some people able to quit smoking so much more easily than other people in their study? And in their interviews with participants in this program, they found that people's responses, people's kind of motivations or reasons for where they were in the change process tended to fall in what they thought of as a cycle or a continuum. So this would be kind of categorized as either pre-contemplative, contemplative, preparative, action, or maintenance. And we'll talk a little bit about what those are, what they mean. So pre-contemplation, Prochaska and DiClemente said, were the participant had no intention to change. When they asked them about quitting smoking, they said, yeah, I don't really see it as a big deal right now, or I don't think I'm ready for that, or that's not for me. They found that people tended to move from there in participating in this program from pre-contemplation to contemplation. And even in the name, you can kind of start to think, okay, they're thinking about it, they're contemplating. Putting this on a timeline, Prochaska and DiClemente said, people who are contemplative are changing in the foreseeable future. It doesn't have an exact time frame like the next 60 days, as some of the later stages do, but we can see that this person is thinking about it, that they are getting ready. Preparation, or sometimes called determination, depending on who you talk to. This is where somebody is taking steps to get ready for the change. They're going to do it in the next 30 days. In the tobacco cessation world, in the public health world, this might look like somebody setting a quit date for quitting smoking. Like on November 1st, that's going to be the day I smoke my last cigarette. And part of preparation might look like, you know, I have 2 packs left to get me from now until November 1st. I'm going to make them last and I'm not going to buy any more after November 1st. That's what preparation looks like, is kind of the mental process and the tangible process around change. Action is that person who is currently making that change. So it's now November 1st, they're doing it. They have no cigarettes left. They are in the middle of it. And the action stage can last for quite a hefty amount of time. It can be like 6 months that somebody is currently working on changing. The reason why we draw a distinction between action and maintenance, which is the change has been in effect for 6 or more months, is that those first 6 months, Prochaska and DiClemente found, are where there is the highest likelihood of relapse, where if somebody is trying to make a behavior change, the first 6 months are the time where they are most likely to struggle to maintain that change, where they find themselves with the most obstacles or barriers or bumps in the road. This is where, for those of us in the room who are clinicians, you might find a lot of your clients is, I've started to change this behavior and I need a little bit of support to keep it going. And lastly, in the early model of the stages of change, or as it's sometimes called, the trans-theoretical model of change, termination is what we think of as the last stage. So this is more of a clinical aspect as well. If somebody's in the termination stage, they're ready to kind of remove the training wheels, remove the additional supports, and maintain that change in behavior long term. So they've gone through at least 6 months of, let's say, not smoking. They don't have any cigarettes left. They have some good coping skills. They're feeling good about their prospects for the future, and they're ready to kind of fly on their own for a little bit. So this is what the stages of change look like in the cycle. You can see that this is a circle with no end. We think of it as having an upward spiral. So relapse is part of the cycle, which is kind of a controversial thing, at least in the substance use treatment community, in my experience. That thinking of relapse or, going back on your behavior change as part of the cycle is something that we don't often want to think about. That it's kind of painful. It's kind of can come with some shame. It can come with some embarrassment that making a behavior change might not last as long or as permanently as we hope it will. But in this model, we think of each relapse or each lapse, each change in behavior back to the old behavior as an opportunity for learning, as part of the cycle. We've kind of baked it into this model. And hopefully that helps us to destigmatize a little bit that we know it's really, really hard to change your behavior, especially if it's something you've been doing for a very, very long time. And so if you fall back into that old pattern, that can be an opportunity for learning rather than an opportunity to label yourself a failure or give up or stop trying altogether. So this is just kind of what the trans theoretical model looks like. And this I pulled from an old bulletin board that I used to have outside of my office when I worked at a hospital, where what do the stages of change sound like? We found that this was really helpful for people in our family medicine practice who were kind of trying to gauge what stage of change their patient was in by finding out what do the stages sound like? Like, what should I be listening for when I talk to my patient about quitting smoking or going to mental health therapy for the first time, or even like starting a new medication that might be really, really hard for them to think about taking every single day. Pre contemplation sounds like I am not ready or I am not interested. Contemplation sounds like I'm thinking about it. Sometimes I'm curious, tell me more. Preparation sounds more like I'm going to start next week or I'm going to start tomorrow. And this one's kind of a tricky one to hear because it can also sound like, okay, this person might be pushing the deadline off a little bit, but we call it determination for a reason. If somebody is saying, I have a plan and on November 1st, I'm going to quit smoking, then we might want to ask a little bit more. We'll get into this when we talk about our MI skills. Okay, so what are we going to do between now and November 1st to get you ready for that? That's a big step. I'm excited for you. How can I support you? Action sounds like I'm working on it. Might be a little shaky confidence there of, yeah, I haven't smoked in 10 days, but I'm just taking it one day at a time, taking it minute by minute. Maintenance, I'm sticking with it. And termination, how do you know if somebody is ready to remove the training wheels? This is a part of my life now. This is something I do. It's old hat, it's habit. I've changed. So, motivational interviewing, the actual meat of this presentation, is based on the stages of change, the trans theoretical model of change. It is a modality that's used primarily by clinicians, but also can be used by just about everyone if it's adapted to the situation to help people move through the thoughts, feelings, and behaviors that help them to change. So we think of this as kind of a triangle where energy can be exchanged in both directions at each point. And again, many of my clinicians in the room have probably seen the cognitive triangle ad nauseum forever. I draw it just about once a week with my clients. And we think of your thoughts as able to change your behaviors are able to change your thoughts, and so on and so forth with each of the 3 points on the cognitive triangle. So, motivational interviewing uses the cognitive triangle to change your thoughts, to change your feelings, to work with what is coming up to help change your behavior, to move you through the process of behavior change. One thing that makes motivational interviewing kind of unique is that it addresses a person's reason why. So, what is their motivation for change? What's important to them? We think of ambivalence, like I'm not sure if I want to change, or resistance, like why are you pushing this on me? I don't know that I really want to do this, as part of the process, just like we think of relapse as part of the stages of change. So we acknowledge that this person has their own values, their own motivations, that what's important to them might not necessarily be what's important to us, but that we are not pushing an agenda on that person, that we are walking alongside them. We are putting forward what is important to them as the reason for change and trying to preserve our relationship with them. And we do that through empathy, understanding, supportive communication, and trying to roll with the resistance and roll with the ambivalence as well. So if somebody is not sure, okay, why is it so important for me to do this? I don't know. Why do you think it is important for you to do this? I would love to know kind of what comes up for you when we start talking about this, or what makes you feel really resistant to this. I get that it's super hard. So, motivational interviewing, the big thing about it that makes it kind of a unique modality is we are listening to what is important to that person. And again, it really relies on our good listening skills. So, one thing about MI is that they love acronyms. There are so many acronyms or mnemonic devices that help us to remember our skills or remember the different parts of MI. The first one that we will talk about today is called PACE, which stands for Partnership, Acceptance, Compassion, and Evocation. And this is kind of the spirit of MI. These are the things that we want to keep in mind throughout our communication with other people. So, partnership, meaning I am here alongside you, I am not in charge of you. I am here kind of partnering with you to make the change that you feel is important for the reason that you feel it's important. Acceptance, meaning this other person has worth. We are empathetic to them. We support their autonomy, even if their decision is not what we would make for ourselves or for them. And we're affirmative. We are understanding of the fact that it's really, really hard to change. Compassionate evocation, we're talking about being compassionate about the fact that change is hard, about the stumbling blocks or the roadblocks that might have gotten in the way over the years trying to make this change. And we're evoking that person's real experiences. We're curious about them. We want to know what they're thinking. We want to know what they're feeling. I put this kind of funny comic in here. I know that like the image quality is not great, but it's this person saying to a younger person, we can say parent to child, I respect your autonomy, sweetie. I just know I can make it better. This made me chuckle because this is kind of not what we're trying to do in MI. If we really respect somebody's autonomy, we don't put ourselves as paternalistic. We don't put ourselves as an expert. Like, yes, we're coming in with some skills, we're coming in with some knowledge, but we are really partnering with that person. And if they ultimately decide, I am not ready to make this change, it is not up to us to convince them. So, how does MI overlap with the LEAP model? The LEAP model is originated by Dr. Xavier Amador from Columbia University, who created this model to help his brother, actually. His brother was struggling with severe and persistent mental illness, and he was having a really hard time trying to help him help himself, essentially. He really wanted his brother to go to treatment. It was really hard to see him struggle. And he was finding that the more that he talked to this person, his brother, who he loved so much, about why it was important for him to go, how hard it was to see him repeat the same patterns over and over again, that he was not getting anywhere productive. So the model that he came up with for what was helpful and eventually generalized into what could be helpful for other people is called LEAP, which stands for listen, empathize, agree, and partner. So LEAP and MI, just quickly, they share a few common traits, and we will get into what they are and why. Our goal is to create some trusting relationships between ourselves and the other person. We want to do that by empathizing with what's important to them, kind of leveraging their motivation, their values, what's important to them to make change happen, and agreeing with their decisions so that we can be partners together rather than teacher, student, professional, client, et cetera, et cetera. So our goal in both LEAP and MI is to promote change talk and keep it going. So what is change talk? We'll put a pin in it and we'll come back to it in just a minute. So a really common question when you are working with somebody with severe and persistent mental illness is, what do I do if this person does not understand that they are ill? We might think of this as, what do I do if this person does not have great insight, does not have great judgment, if it's really, really obvious to me that something is up, but it is not obvious to them, or because of their mental health, they are not able to kind of see the forest for the trees here. I am not going to do a great job pronouncing this. I did practice, I promise, but every time I'm confronted with it, I cannot say it correctly out loud. But clinically, we think of this as an inability to understand that one is ill. And this is exactly what Dr. Amador was experiencing with his brother, noticing that he simply did not understand that what he was seeing as a very clear, a very normal, a very everyday reality for him was really concerning to him as his brother. So we think of this clinically as having a lack of awareness of a neurological or psychiatric condition. This can be associated with mental illness, it might be associated with dementia, with another neurological condition such as brain lesions. This can happen for a lot of different reasons. And it's characterized by conscious awareness of, or affecting your conscious awareness of your judgment, your emotions, your memory, your ability to have executive function skills, your language, your motor ability. Again, these things seem totally normal to you, but to other people who are observing, something seems like it's a little off. And this word comes from the Greek for to not know a disease. The reason why we're talking about this today is that it can be very, very difficult for loved ones. It's very confusing to experience that there is a change in your loved one, in your relative, in your friend, and they can't understand or perceive their symptoms. So LEAP, created by Dr. Amador, was designed to kind of work with this lack of awareness. Again, the goals are really similar to what they are in MI. Our goals are to gain trust between ourselves and the other person, to lower defensiveness. Again, the title of his book on the right, I Am Not Sick, I Don't Need Help, How to Help Someone Accept Treatment. This might sound a little bit like, okay, we're pushing this person to do something they don't want to do, but really it's less about pushing them into the decision and more about, I want to help you in some way. It is clear that what is happening is not working. How can we become partners to do something that will be better for you? And help me understand, what do you think would make a difference for you right now? This creates both understanding, empathy, respect. Why this is kind of important, or why this is part of this presentation today, is that about 30% of people with schizophrenia and about 20% of people with bipolar disorder experience a severe lack of awareness of how their mental health is impacting their behavior. This is from data collected by NAMI this year, 2024. Um, this is important because not being aware of lack of insight or lack of good judgment increases the risk that negative outcomes will happen. So if I'm not aware of how my mental health is impacting my behavior, I'm more likely to experience housing insecurity or to become unhoused. I'm more likely to be arrested due to reckless behavior or lowered inhibitions. Um, it also really damages relationships as well. Many family members might assume that their loved one is doing a certain behavior on purpose. Um, they might assume they're doing it to be manipulative, to hurt someone else, to avoid accountability, to kind of um, just be spiteful. These are all things that you might hear from loved ones of somebody with severe and persistent mental illness. Um, they might also really feel this very natural desire of, I just wish this person would wake up and do what is good for them. I really want them to change. And that can cause a loved one to fall into a pattern of learned helplessness. Like, I see that there's a problem, but it is just too hard for me to change, or it's just too hard for me to make my loved one change. There's not a lot that I can do at this point. All I can do is just ride it out. So, how do we work with this, both as loved ones and as clinicians or anybody who's affected by this topic today? Again, our big goal is to create trust, create a strong relationship between us and the person who is refusing help or who is resistant to help. We do this by finding out what their intrinsic motivations are, what their values are, giving them empathy and respect, which they may not always be experiencing. Again, it can feel really affronting for somebody to say, you are sick and you do need help. I know I certainly would not like hearing that if I wasn't ready for it. And that can come in the form of acknowledging that change is super hard. And in the fact that it's hard, how can we move the change process forward by just starting to talk about it? Even one conversation can start to set us on the path, one tiny, tiny step at a time. So, hard reminder, one thing that I really bump up against in my clinical work sometimes, we can't make anyone do anything. Feels terrible, especially when we know that another choice might serve them better, when it's really hard to see somebody that you care about who is struggling in the same pattern. But ultimately, we can't make them do anything that they do not want to do. So, what can we do to help that person at least reduce the harm that they're experiencing? So, how do we use MI as caregivers? So, again, if you are a caregiver, if you are a person who is partially or fully responsible for someone who is not aware that their mental health is impacting them in this way, what can we do? We know that it affects their conscious awareness. We know that there are behaviors, there are cognitive changes that are really obvious to us, but are not aware that that person is not aware of themselves. So the first thing that we can do is kind of not try to convince them that something is wrong. And I know that that sounds really, really hard. We're going to talk about how to do that. So there may be a desire for this person to get help, but it's difficult for you and that other person to get on the same page. This might be due to their lack of insight. It might be due to a million other external reasons. We think about like what are all the influences on a person's life, on a person's decision making. There might be some really actually quite good reasons why they're not ready for change. And for you as a loved one, this might sound like, uh, don't they know that they're sick? Don't they know that they're struggling? How can this be so obvious to me, but so unapparent to this other person? This is the fourth or fifth time that we've had this conversation about them quitting drinking, and they just don't seem to be moving the needle on this at all. Why is this happening? Again, there might be some reasons both internally and externally why it's not happening. And the first thing that we're going to do is try to drop our judgment and get curious about what those reasons might be. Looks like these slides are a little out of order, my bad. But again, this is a pretty common problem. 30% of people with schizophrenia might experience this, 20% of people with bipolar disorder. Okay. So cognitive changes might cause some uh, negative outcomes in our external world. Like we said, might cause housing insecurity, job insecurity, might lead to arrest. All of this is super concerning if you are a caregiver or a loved one. Um, might seem like this person is being manipulative or reckless. Again, we might have thoughts like, why can't they just act right? Or there's no point in trying to help them anyways. We've been having the same conversation for 10 years, or I've been seeing them fall into the same pattern for forever now. Why would they change now if they haven't already? And this is the moment where it's important for us to drop the judgment and get curious. This might look like saying to them, I know that we've been having the same conversation for a super long time. And I am just as tired of having it as you are from hearing it from me, I'm sure. And I know that it's really hard to change. And I want to understand kind of what's going on for you. Why do you think this keeps happening? So, using MI when somebody lacks awareness or lacks insight looks like using reflective, open, and adaptive processes. Looks like um, trying to be as curious as possible in a conversation that might bring up some feelings for you as the caregiver, just like it might bring up some feelings for the other person as well. So, the next MI acronym that we're going to use today is OARS, which stands for open ended questions, affirmations, reflections, and summaries. And these are all different types of MI skills that you can use in conversation to help your loved one make some informed, self determined choices. So we're guiding the conversation. We are trying to be, again, curious. We're trying to listen really, really carefully to what that person is saying without directing. Um, Again, for the clinicians in the room, I feel like there is sometimes a perception that our job is giving advice. And sometimes it's about giving information, but it's not often telling people what to do with their lives. Uh, so, MI is a really good example of why that does not work very well in most situations. That if you were to go to your loved one and say, this is what I think you should do, and this is how I think you should do it, that they are not likely to receive that information any differently than they have the last couple of times that you've talked about it. Or they might even become defensive. They might feel like, who are you to tell me what to do? You make mistakes just like the rest of us. Um, Again, if we want that person to drop the defensiveness so that we can have a compassionate and empathetic conversation, we have to remove our expert hats. We have to try to follow rather than direct. We do that by using ORs. So, ORs, again, open questions, affirmations, reflections, and summarizing. Open questions are basically any question that does not evoke a yes or no answer. Sometimes those closed questions can be helpful, like, hey, is it okay um, if we talk about your mental health? that's a yes or no question. It's always good to ask permission. Um, there might be times where it's even just necessary to do that in a tough conversation. But if we're trying to understand and be curious, using open questions tends to get us more information from the other person and tends to get us a much richer narrative than asking closed questions. This might sound like, how would you like things to be different? And keeping in mind, this person has probably heard from you or other people before what should be changed. An open question like this asks more about it's clear something is not working. What do you see as the problem? A in OR stands for affirmation, and we're affirming that person's strengths, their past efforts, their past successes. We're really trying to instill some confidence in them as well. I mean, it is not only hard to change, it's also hard to stay the same, which I know sounds like super corny therapist speak, but it is really hard to keep doing the same thing over and over again and experiencing that pain over and over again. So, affirming the other person can sound like, I appreciate that you were willing to talk to me about this. Um, I know it's not easy to talk about your mental health, and I don't take it lightly. Can also look like um, this person talking about the last time they made a behavior change. Like, I was able to stay sober for 6 months back in 2000, but I haven't been able to do it for that long since then. Affirming that effort might sound like, um, I know that you've done it in the past, and that tells me that you're one tough cookie, that you can probably do it again. And let's talk about what made it possible for you to do that back in 2000. An open question might be like, what do you think helped back then? That is a long time, 6 months. Reflections are exactly what they sound like. You are reflecting back understanding or checking your understanding with the other person. I like to start this with, if I'm hearing you right, or tell me if I've got this, or sometimes even kind of using an either or a both sides. So, like, on the one hand, I hear you saying that you want to go to treatment because you're tired of living like this. On the other hand, I hear you saying that you don't want to give up your apartment. Am I hearing you right? Or do you think I've got it? And that gives the other person a chance to really fine tune your understanding, gives you a chance to get more information about, I'm hearing this ambivalence, and what do you think is contributing to it? And you can see that that helps you to move from pre-contemplative to contemplative with that person, and maybe even into preparative as well. So you don't want to give up your apartment, but you do think it would be good to go to treatment. Um, what do you think would need to change for you to feel better about not staying in your apartment? And lastly, in ORS, we are using summarizing, which is a little bit different than reflecting. We're not just repeating back what we've heard, but instead, maybe we've been listening for a longer period of time, and we're trying to convey that we understand the larger point of the conversation. So, with the example that we've just used about the person going to treatment, I hear you saying that you are not feeling ready right now to go to treatment, but that some things would need to change before you were ready. Again, this is kind of a bigger summary. It might even include a little bit of interpretation. This might look like not just repeating back the words that you've heard, but interpreting meaning, like using your own words as well. I hear you saying that you're feeling a little bit back and forth, a little bit ambivalent about this decision. I hear you saying that you're feeling kind of nervous about it. And again, if your summaries are off, part of staying curious, part of staying open is being open to being corrected by the other person. So if they say, no, I wouldn't say that I feel anxious or fearful about it. Oh, okay. Then what would you say? Like what's a better word for that? And this can be really, really hard, especially when you feel like you've got it, like you understand, but the other person feels like there's more that you're not getting. So again, we try to keep in mind that spirit of MI, that openness, that curiosity, trying to take in as much information without directing the conversation. Some general tips for using ORs as a caregiver. We want to pay attention to change statements. So if we think about the stages of change, we want to pay attention to those little parts of the conversation that give us an inkling of where that person might be in the change process. So, for example, if somebody is saying, I'm just not sure how to start, or I don't even know where to begin, that might start to prick your ears up over time of, oh, this person is contemplative. You might also hear them saying, I bought my last pack of cigarettes last week. That person is preparative. They might start off the conversation with, you're not going to change my mind about this. That person is pre-contemplative. And again, this might start to seem like a little bit formulaic. It's kind of it's helpful to have the stages of change in your mind so that you know how to approach a conversation, but human behavior does not often fall into neat, beautiful little boxes like this. So we're paying attention with the full knowledge that it may not go as smoothly as I'm laying out for you here. And also, even calling the stage pre-contemplation suggests that, okay, that person, they're going to be contemplating real soon if we can just hang on, if we can just keep talking to them, which is a little presumptuous on our part. They have the full right to make the decision to not change. I have said it many times to my clients that can't always support your decisions, but I can support the fact that you have the right to make them, that you have autonomy over them. So another thing that we want to do when we are using ORs is listen for ambivalence, kind of that both sides or that two perspectives. On the one hand, I hear you saying X, Y, and Z. On the other, there's A, B, and C to consider. So we had the example earlier of going to treatment, giving up your apartment. Another time that this might come up is if somebody is I hear it all the time that people are ambivalent to treatment that involves groups. There's something really, really scary to people about going and being among a group of people, even when we on the other side of the conversation might be thinking, like, I think it could be really good for you. I think it could be so good for you to connect with other people that have been through what you've been through. They might hear that and think, yikes, I don't want to talk to anybody else. Talking to one person is enough for me. So, on the one hand, I hear you saying that something needs to change. On the other hand, there's the fact that groups are super scary. We can end this conversation or end this reflection with an invitation. Did I miss anything? Or does that sound right? And when we end with this invitation to correct us, to add more information, to thicken the narrative, we want to be curious and open to being corrected again. I might be wrong. I am, I don't know everything about everybody. I am just trying to do the best I can to listen. Being curious means thinking about what are this person's values, what are their motivators, and what are their reasons for change or to not change. Here we have, again, kind of a silly screenshot from The Simpsons. And we see that Homer is working crazy hours at the nuclear power plant because he wants to make a better life for Maggie, his youngest kid. Many of us probably would count our family members or our loved ones as a big reason for change. Our family members might also be a reason to not change. For example, I have worked with plenty of clients for whom a big reason why they are not able to or not ready to go to treatment is they have little kids at home. And they might say, I don't feel ready to go to treatment because I don't want to leave my kids. They might also not have reliable childcare or say, I don't have anyone in my family that I would trust with them for 8 hours a day while I'm in IOP. Daycare is expensive. I know I don't need to tell anyone that, but it's often as much as a rent or mortgage payment for people. So, being curious means understanding or trying to have understanding for what these reasons are. And even if to us, we might say, okay, daycare is expensive, but it's worth it. You've got to go to treatment. That might be enough of a barrier to put that person off from the idea completely. And we want to be empathetic to that. Like, I hear you saying that in order for you to go to IOP, you would need to leave your kids at daycare or leave them with your mom, and that you don't really trust her to watch your kids. I can't imagine how painful that is to not have someone close to you that you can rely on for childcare. And I can tell that you really care a lot that your kids are well taken care of. Tells me that you're pretty strong, that you're a really good mom or a really good dad. So, this has been a pretty general overview of MI. Now, let's look at how this might look a little different with more specific populations. So, with people with different mental health diagnoses, with people with substance use disorders, how might we target this intervention a little bit more in those specialized cases? So, for our loved ones who have severe and persistent mental illness, such as schizophrenia, such as bipolar disorder, in my caseload, this might look like severe OCD. We would use an adapted version of OARS. So, we still want to be leaning pretty heavily on open ended questions, affirmations, reflections, and summaries, but we want to kind of have a little bit more of a tailored approach. So, for people with SPMI, severe and persistent mental illness, asking a why question might be really hard for them to answer. Again, if somebody is struggling with insight, they might be more likely to ramble a little bit. They might not have great focus in their responses. And so, asking a question like just straight up why, like they say, I don't want to go to treatment. And you say, why? That might lead them onto a very long, very disorganized, very distressing for them, distressing for you as well, narrative about why it's not a good choice right now. It tends to, instead of lowering defensiveness, that might really escalate the conversation. Also, can be just kind of confusing for everybody involved. Well, I don't really know why, or uh, here's a list of the 27 reasons why it's not a good time and it'll never be a good time. So we might try to avoid those questions and instead ask about how. So instead of why is it not a good time, how would things need to change for it to be a good time? Another thing we might do differently with people with SPMI is allowing extra response time. So this might look like somebody who is very quiet, very reserved, takes a little time to organize their thoughts before speaking, maybe even more than you might experience in a conversation with someone who is not struggling with severe and persistent mental illness. One thing that us therapists have to get comfortable with that I think other people don't get as much practice with and really find uncomfortable is sitting with silence. I hated it when I was starting out as a therapist. I hated sitting there in silence and waiting for the other person to talk. I felt like I was failing at my job. And now I think both my clients and the people in my life are sometimes a little bit surprised by how long I'm comfortable sitting with somebody who has not said a single word. But that's because that extra response time for someone to gather their thoughts is really important. It gives them, it shows respect. It allows them to have some time to collect themselves to show that you're worth waiting for. It also might be that, again, somebody is struggling with insight, struggling with judgment. Their speech might be a little bit disorganized. So allowing them extra response time, even if that means that they are totally off focus, shows the respect, shows the caring, shows the empathy that you want to convey in this conversation. To help focus a little bit, it is helpful to ask just one question at a time. And I am super guilty of this as well, blending two thoughts into one when it might be more focused to just ask one question, even if it feels more broken up. This could look like, how might things need to change for you to be ready for treatment? Give the person some time to respond. What might need to change in the next week for you to go to treatment in November? Or what of the things you just described would have to change first? Also, with ORs, we're thinking about open ended questions and affirmations. For people with SPMI, we don't want to exaggerate our affirmations. Again, if we're trying to lower defensiveness, we want to be affirmative, we want to be empathetic, but if we're really over the top, it might come across disingenuous or like a little patronizing. That might make someone feel quite defensive. So instead of, wow, you did it, you quit smoking for a whole week, that's amazing, I've never heard of anything like that. Just being concrete, being proud, being appreciative, but keeping it brief. Wow, a week, that's awesome. You want to talk about it? You can convey a lot without saying a lot. So, thinking about your body language, your tone of voice, your manner of speaking, and using that to convey your affirmation rather than words and words and words and words. We can use reflections to help develop somebody's insight. So, if they are struggling with following their own narrative, these are the 27 reasons why I'm never, ever going to go to treatment. Using reflections can help us to kind of consolidate that list of 27 things to the most important headlines. So I hear you saying that your job, your pets, your apartment, and your friends are all things that you would be really sad to leave behind if you went to inpatient treatment for 30 days. Does that sound right? Then you might hear them say back to you, yeah, there are a lot of things keeping me here that I don't want to be away from. That's helping them to understand what's important to them, what their reasons are in a more concise way as well. It also gives you a little bit of shared language to continue the conversation. And lastly, those types of reflections or summaries, we want to use a little bit more frequently with our loved ones with SPMI. So that might look like every third or fourth response from them saying something along the lines of, here's what I hear from you, or it sounds like X, Y, and Z, or, based on what I've heard from you so far, here's what I hear you saying. You can also ask the other person to give you a summary. So, okay, I hear you saying that there's a lot of reasons why it's not a good time for you to go to treatment. Can you give me the top three? What are the three biggest things that are keeping you right now? And that not only allows the person to give you kind of a summary of what's most important to them or what's top of mind for them, it also gives you a chance to understand what is most important to them. So you're conveying curiosity, you're really listening to them, they are expressing to you kind of the hierarchy in their motivations and their decision making. So, some examples of what this might sound like: open ended inquiry, not using why statements or avoiding them when we can, could look like, what are you feeling right now? Or how have you been coping? The first one might be a little bit more applicable if you notice that the person has had a change in their affect. Their facial expression is different, their body language is different, their eye contact is different. Hey, I noticed that something's off. What are you feeling right now? That might be an open ended inquiry. Affirmations, again, we want to keep it brief. Forgiveness is important to you. You've been trying hard to make this right. So even if this person is trying in a way that doesn't make sense to us, if forgiveness is important to you, then why are you doing what you're doing? We want to reflect back that we understand, that we are affirming their efforts to change so far. You've been trying really hard. You've been doing everything you can think of. Um, if I were to say this in a way that was a little bit more natural to how I talk, I might say something like, you're really throwing everything at the wall here. So as you hear these examples in my presentation, you might start to think about, okay, how do I make this sound like me too? How do I make the language of MI feel more like my voice? Reflections, you're really frustrated with how this has been going. A lot has happened and you just want to feel trust again. So some things that we might reflect back, did that person say they feel frustrated? Did they say they want to feel trust again? We might be pulling little pieces that we've heard from the conversation out to convey that we're listening. Summarizing, we're taking a big part of what they've said and we're condensing it down to express that we understand, that we're listening, make it more concise so that we can talk about it. Sometimes the stress can be too much for you. It's been really hard to stay in treatment and you want custody back so badly. An example that we could end this with, where should we go from here? I've just summarized all the things that we're talking about. What do you think we should do next? So, a few things that we might do differently moving from clients with SPMI to clients who are dealing with substance abuse. And again, there is not like a perfect clinical presentation with which to use these skills. Often, many of us are working with clients or working with loved ones, even who are dealing with both severe and persistent mental illness and who are coping with it with substances. So, if somebody is dealing with substance misuse or substance abuse, one consideration we might add in to everything that we've been talking about is listening for change talk and knowing the difference between change talk and sustain talk. I told you that MI loves acronyms. They also love little sayings like this one. Change talk, again, it sounds like somebody who is contemplating change, who is preparing for change. Somebody who is using sustain talk, they are more pre-contemplative. They are talking in a way that does not promote behavior change. So sustain talk, marijuana's never really affected me. Change talk, if I keep smoking, I'm going to fail my drug test. And you might even hear these two things in the same conversation. You might even hear them in the next breath of each other. So we might reflect that back using kind of a both and statement. So on the one hand, marijuana doesn't really affect you. On the other hand, you're going to fail your drug test if you keep smoking. What do you think about that? And keeping in mind that, especially when it comes to substance use, ambivalence, feeling two ways are super normal. When we talk about substance misuse and we're talking about changing that behavior, we are talking about taking away a coping strategy for that person or them voluntarily giving up a coping strategy. So, feeling both nervous and hopeful, feeling both angry and resigned, feeling two ways is completely normal, and we can validate that. Sustained talk, if that's all we're hearing in a conversation, it indicates a lack of desire about how to change, not a lack of knowledge. And so, if somebody is mostly using sustained talk, like marijuana's never really affected me, they seem really pre contemplative, it's not that they don't know why it would be important to change, it's that they don't want to right now. And as hard as it is to accept that on the other end of the conversation, that is the reality that we are in. This is a thing that's really, really hard for us as caregivers and care providers, um, because we think if they could just see how much better their life could be on the other side of this change, or if I could just tell them about, what group treatment would be like and make it seem so much less scary, then they'll want to. That may not be the case. Again, we're putting our agenda, our values onto that other person without really understanding what is going on for them. They might know all about it and still think, I just don't want to do that. We have to be okay with that, at least for this one conversation. So, in MI with substance use disorders, one way that we can listen for change talk is using an acronym called DARN-CAT, which is our last acronym for today, I believe. So, DARN, the first half of the acronym, is what you will use to guide the questions that you ask, and CAT is what you hear in response. DARN stands for desire, ability, reasons, and need. And CAT is commitment, activation, and taking steps. So questions you might ask using DARN CAT might sound like, how do you want this to change? Ability is asking about what limitations or what strengths does that person have in changing this behavior. So what ideas do you have to stop smoking? Reasons, again, we're trying to understand motivation or values. What do you think the downsides are of continuing to use drugs? Or in my own voice, that might sound like, so what happens if you decide not to go to treatment? And need, what needs to happen for you to feel ready to quit? This is curiosity about the other person's situation and the internal or external motivators that might be keeping them in the same place. So, what needs to happen or what needs to change? What supports need to be in place for you to do this? And then again, we are listening for commitment, activation, and taking steps, which sound like, I want to blank. I'm ready to blank. Taking steps, I already did this. I cut out my lunchtime smoke break. I left a message with recovery resources. I reached out to a couple therapists. So we're listening for commitment, activation, and taking steps. If we hear those things, this is a great time to be affirmative. You cut out your lunchtime smoke break. Okay, that's a big step. How do you feel about it? Or, so you did that yesterday? What was that like on the first day? So using these skills in the various stages of change can be kind of tricky. Again, the more you practice this, the more it will become more like a language, more like a skill that you're used to using. And one way that we do that is by remembering what the stages sound like. I put these exact same things from the earlier slide here on the right, and kind of holding those in your mind and trying to really wrap our minds around, if somebody is saying, I'm not ready, it might not sound exactly like those three words. It might sound like a million excuses why they're not going to do it. This is a great time to use a reflection like, I hear you saying that work, your kids, and your anxiety about going to group are the things that make you feel not ready for treatment. Do I have that right? Our goal is promoting change talk. So if somebody is pre-contemplative, if they're giving us a million and one reasons why they're not ready, our goal is to get them thinking and talking about it, even if they don't really seem bought in on the idea yet. Even if they're not saying, all right, next week is the big day, I'm going to do it. Our goal is to just continue the conversation, even for a few minutes. Your loved one is in the driver's seat here. We can't make somebody change, only walk alongside them. This is the hardest part to accept for all of us. We do that by getting curious. We do that by being empathetic. This also, even if it leads to perpetuating the same behavior for a while or a long time afterwards, it can help you to have a better relationship with that person too, because it preserves the communication between you. It shows that you have empathy for that person. And empathy tends to beget empathy, in my experience, that if we're curious and empathetic to another person, that even if they continue to struggle in the same pattern, they are more open to talking to us next time or opening up to us next time. So that is it for me. These are my references. There are a lot of them. And I think we probably have some time for questions and things.
Yes, thank you so much for all of that very useful material. So yeah, we do have time for questions. Feel free to put the questions you may have in the chat. I'm also going to put the link to the surveys. So now note there is one general evaluation. That's the link I'm putting in now. And there's also an evaluation specifically for CEUs. So I am putting that in the chat now as well. And remember, if you do want your one CEU for attending this webinar, you must be a licensed counselor, social worker, or marriage and family therapist. And you must also provide your full name, license type, and full license number in the designated question for that on the CEU specific evaluation. So I did just put those two links in there. And again, this is being recorded, so if you want to view it at a later date, we will upload it to the NAMI Greater Cleveland YouTube channel later this week, and I will also send these slides to you in a follow-up email shortly after we end the session. I think that's all the housekeeping I needed to provide at this moment. Let me just check. Yeah, so it does look it's the same? No, it's actually not. You'll notice that in the second link at the very bottom, they're almost identical, but at the very bottom of the second link, there is a spot to put in your name and license number and license type. So almost identical, but CEU has one more question in there at the bottom. I did just check that they're two different links. Yep, no problem. So I'm not seeing any questions. And Josephine says, thank you. This is so useful, even if someone is in the action stage after relapse. Yes. Okay, so we have a question from Aline. When the issue is lack of trust for therapists, counselors in general, due to negative childhood experiences, what motivational interviewing questions can we ask to encourage considering therapy? So I guess this question might be, if a person's had negative prior experiences navigating the mental health system, how might we utilize motivational interviewing to encourage them to reconsider services?
This is a great question. And it is one that I feel like if somebody gets in the door of therapy, that like I often hear a lot about somebody's past negative experience. So I would be curious about the same thing. I think that one question or one kind of line of questioning that I might want to use is some curiosity and some open questions around that negative childhood experience. So, can you tell me a little bit about what happened the last time you were in therapy, or um, even kind of once you have that understanding and you've reflected that back, you've checked your understanding with that person, and okay, it sounds like from what you're saying, when you went to therapy in middle school, that person was really dismissive of your concerns. And instead, they uh, kept telling you how you were feeling. I can imagine that's so frustrating. Some questions that we might throw in there as well might be some of those how questions and asking about somebody's needs. So, how would things need to be different for you to go back? Or if we could change one thing about that experience, or if we could change anything about that experience to have made it better, what would we change? So, again, kind of curiosity, understanding their needs, understanding their reasons for not going to therapy. Um, if you're lucky enough that somebody does get in the door with you as a care provider and they're saying, I had this awful experience and I'm a little hesitant to be back, this might be a great time for an affirmation too of, wow, I can tell that you really had to get past a lot to get here with me. And I'm so glad that you did. Great question though.
A couple more things. I did get one question that I'll pose to you, Madeline. I did also want to mention next Monday at noon, same time on Zoom, we are having a webinar, not worth CEUs, not a clinical topic, but it's on financial planning for parents of adults with serious mental illness. Figured that many of you on the call today may also be interested in that one. So I did put the link to that in the chat just now if you want to register, and that will also be recorded. And I got another question, Madeline. Do you have are there any guides or resources? Maybe they're listed in your resources here, but prompts or more examples of open-ended questions that caregivers could use with their adult children with mental illness, particularly when that person is just in those same patterns, as you've been saying.
Yes. So in my references, there are a few different treatment improvement protocols or tips from SAMHSA. This is one of them, enhancing motivation for change in substance use disorder treatment. There are a couple others as well that I will highlight, not these. This one from Mint, which is the Motivational Interviewing Training Center, and this one from the University of New Hampshire, and also this advisory from SAMHSA. But all of these are either previous trainings, a lot like this one, or they are tips, which are kind of like treatment protocols or best practices documents that break down, if you were to start doing this with clients, how would you do it and what would it sound like? When I was in grad school, we were encouraged to just download as many of the tips off of the SAMHSA website as we could in case they ever get archived so that you have these kind of treatment manuals with you. And they are so helpful and I use them all the time. So highly recommend checking those out.
Okay, a couple more questions in here. You kind of addressed this a little bit at some point in the presentation, but any further thoughts you want to share on supporting individuals with co-occurring serious mental illness and substance use disorder?
Um, well, I guess like one thing to think about that we talked about briefly before is trying to keep in mind that it might be that both sides of the co-occurring disorders might be impacting that lack of insight, that there's no one clear cause that we're trying to treat here. It makes it a little bit more complicated for us that somebody might be struggling with bipolar disorder and they might also be using substances to cope with that or to self-medicate. This is a presentation that you probably see a lot, that substances are a really effective way of changing what you feel. And so for someone with a mood disorder, that can be very tempting or very effective, very useful. So in trying to understand, know, why is this person stuck in this change process? Why are they not able to change? Part of that might just be acknowledging, this is the best way that they've found so far to manage these symptoms that are so, so painful. And so something would need to be really, really attractive or really, really effective to take them from one behavior to the next. And this might mean that you're in a much longer process of using motivational interviewing skills with that person.
Thank you. Looks like there's a lot of great motivational interviewing resources in these references. So again, some folks are asking about more resources. I will send an email with these slides to you when we wrap up here so you can take a look at some of these resources on your own time. When an individual with serious mental illness and anosognosia has very rigid thinking and their decisions have negative consequences, such as threatening their health, creating substantially more work for the caregiver in the rescue, any advice on how to handle that? In short, when the consequences make it difficult to walk alongside my adult son.
Hmm. This is also a great question. Um, my thought on this is that, I mean, for one, it sounds like it is really difficult, and I want to acknowledge that like this is so much work for you on the caregiver side, and I'm sure that that is equally as painful. Um, my thought is that if somebody is experiencing these negative consequences pretty frequently, if they're in this pattern of experiencing harm over and over again, that our goal might be more about harm reduction than about total behavior change. So, you mentioned somebody who is risking their health. It might look less like, how do we get you to stop doing this thing completely that is causing you health concerns? And instead, is there any way that we can reduce the frequency that this is happening? Is there any way that we can make it safer? Is there any way that we can add additional support so that even if there are some consequences, maybe those consequences are less painful, are less harmful, or are happening less frequently? Um, that's kind of my first thought on this. I would really recommend checking out some of these resources in the references page because I know that specifically some of the SAMHSA documents might have some ideas for you if you're willing to check them out.
One more question I see in here. Any ideas for how to best re-engage a loved one who has incorporated you into their paranoid delusions? You become part of one of their fixations of their paranoid delusions.
Ooh, that is a tough one too. Um, hmm. I guess without knowing like exactly what role you occupy in that paranoia or in that delusion, um, it might be helpful to, in these conversations where you are using MI skills, trying to gain understanding of the role that you are occupying for them, I guess. Like, I think that if that person believes that you are out to get them, for example, um, instead of saying, no, 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 I'm not out to get you, or I don't know why you would think that, maybe a question that you could ask might be, help me understand what you are feeling right now. Help me understand what leads you to believe that I am out to get you. Or is there something that I can change that might make you feel a little safer when you talk to me? If that's really not working, it might also be helpful to bring in an additional loved one if you have one around who is willing to step up and use these same skills and say, I need to tap out for a minute. And that's a thing that I think a lot of caregivers really struggle with is both having adequate support because you occupy such an important, such a major role, but also being able to lean on it, especially feeling like you're allowed to lean on it. Um, this might be a time where you also go to your own individual therapy and say, I don't really know what to do, and this is how it's making me feel. And I am struggling to show up in these conversations. And that person could, support you so that you can show up the way that you want to.
Yeah, just for everyone else's awareness, I'm going to put in the chat a link to um, so Non-Greater Cleveland offers the LEAP workshop about twice a year. We're not able to record those workshops, but Dr. Amador, who developed the LEAP method, did a recorded presentation about LEAP. I think it's like an hour or 90 minutes with NAMI National, and I'm going to put that link in the chat since I think as we start to, like, I notice a lot of these questions are really specifically pertaining to the individuals with psychotic features in their illness, in addition to the anosognosia. Dr. Amador's teachings and the LEAP model in particular are really helpful for that. So I'm going to put the link to that in the chat now, so that you can view that at your leisure. Okay, so I just put it in there.
I
All
would
right.
add, Matt, too, that like a lot of these specific questions about like what should I do in this situation, there are some pretty good like role plays or examples of how to use MI or how to use LEAP with people with psychotic features in their mental health on YouTube as well. That if you were to put in like motivational interviewing plus schizophrenia or plus bipolar with psychotic features, there are some role plays by either, people who work at the LEAP Foundation or people who work at Mint, but also like grad students who are doing this for a grade. And those are super helpful in learning how to incorporate these skills into your conversation.
Yeah, thank you for that. Yeah. Yeah, I'm glad we were able to offer this today to partly bring to everyone's attention more of the commonality between LEAP and motivational interviewing. We're happy to do what we can with LEAP, but there's so much more you can explore with motivational interviewing as a whole. And like Madeline said, there's so much resource and multimedia out there about motivational interviewing. So you can browse YouTube at your leisure. All right. I think we covered all the questions. Uh, Thanks everyone for joining us. We had a great turnout today. Again, I'll make sure this recording is posted to our YouTube channel later this week, and I'll send you the email with these slides in a moment. Thanks to Madeline for joining us, and hope you all have a great day.
Thanks, everyone.